Some of the subcategories for the mental disorders that you can find in the Diagnostic Statistical Manual. First group that we're going to talk about are anxiety disorders. Now, here, when we're talking about anxiety, it's not like we would diagnose you with any of these disorders because you feel anxious about a test. I'm talking about that more severe type of anxiety. Things that would hit you like phobias, or if you have obsessive compulsive disorder, or even like post-traumatic stress disorder. Those would be in that category of the anxiety disorders. Now, in terms of mood disorders, these are going to be demonstrating issues and problems that's more severe in terms of your mood, such as persistent depression, what was used to be known more as major depressive disorder. When we're talking about the bipolar disorders, uh, such as with having issues alternating between periods of depression and with mania. Schizophrenia and the other psychotic disorders. Here, this is when we're talking about schizophrenia that's showing and demonstrating different types. That being, you might have paranoid type, you might have a disorganized type, or the disoriented. Then there's the dissociative disorders. Here, we talk about dissociative identity disorder, which used to be called multiple personality disorder. We're talking about dissociative amnesia, where a person, they pretty much kind of forget a traumatic event. They can't recall anything prior to or sometimes after a traumatic event. That would be called a dissociative amnesia. There's also dissociative fugue, and that's when you're pretty much feeling just altered in terms of being pulled away from yourself. You're outside of your body experience type things. The personality disorders, these are more of these lifelong, really no cure, need to learn how to cope with type of disorders. What falls into this category is, for example, the borderline personality disorder, where a person's dealing with both mood and impulsivity. They have problems with their relationships. They have an all or none type of attitude. You have the antisocial personality disorder. These individuals, they show no remorse. They don't care what you think. It's about them, and they think that they can have or do anything that they want. And they'll go and do anything they want, even if it's illegal. Sleep disorders we kind of went over earlier in the other chapters. Remember, we had insomnia, we had the night terrors and those types. So that's the sleep disorders category. You have the substance-related disorders, where we're talking about opioids, we're talking about alcohol, as well as different other drugs. Intellectual challenges or disabilities. These are in terms of when a person has adaptive and intellectual functioning issues. Used to be called mental retardation. We try not to call it that no more because it's kind of derogatory, and we realize that. So we now talk about it, a person having intellectual challenges, and not mental retardation. We just got through talking about the eating disorders, and then there's what we call the somatoform disorders. And this is, I kind of tapped on it when we talked about in motivation and emotion, when we spoke about eating disorders, and I was talking about physical distortions for an individual. Uh, well, kind of goes on the same line. Some people with somatoform disorders, they might be dealing with some preoccupations with the physicality, even if it's not present. And as you can see, we still have more subcategories to look at. Fictitious disorders, the best way I can say it is individuals with fictitious disorders, they kind of want you to feel that they're ill and they're not. But they want people to believe that. One term that you would want to know about is what we call malingering. With malingering, these individuals, they're pretty much faking the funk. And with that being said, sometimes they'll do it for monetary reasons. They'll try to see if they can get disability or they can get workman's comp, and they'll say that there's something wrong with them when there really isn't anything wrong with them. The sexual and gender identity disorders are dealing mostly with issues where people have problems performing sexually, or in terms of having some gender identity issues. Uh, Most times with confusion. Once upon a time, unfortunately, homophobia used to be considered a disorder. Thankfully, we realized that that's not the case, and it was removed from the Diagnostic Statistical Manual. It was in the Diagnostic Statistical Manual second edition, but it got removed, thankfully, by the third edition. So we're now up to the fifth edition, therefore, that's not the case. When we're talking about somebody with some type of identity confusion, it's not that we're looking at their sexual orientation per se, but we're actually looking at how to help them deal with the struggles they might have identifying with themselves in a particular stance or way. Impulse control disorders, these would fall in lines of talking about people that have like kleptomania. I think I talked about my brother in the past, but if I didn't, I had a brother who he stole just for the pure joy of it, just to do it. He didn't have no reason, didn't need the extra money. He just liked stealing to see if he can get away with it. Hence, he was a kleptomaniac. Um, you also have other types. You have people who like setting fires because they like to see the flames and the glitter from it and the flickering. They're pyromania. That's as well as those who are pathological liars. You could put as an impulse control disorder. You could talk about those who have pathological gambling issues, that they'll take their rent and they'll go and gamble it rather than pay their rent. Okay, so another set of disorders that we might be talking about and looking at is what we call adjustment disorders. Now here, this is when we have people having difficulty transitioning in a particular situation within their environment. Sometimes a person might have difficulties due to a new job or the loss of a job. They might have difficulties due to a loss of a loved one or even a pet. Divorce can be considered one of those, as well as other financial difficulties. Now, there are disorders that would come under lines during early childhood and adolescence, and these would be things like autism, dealing with learning disorders, like dyslexia, looking at attention deficit disorder or attention hyperactivity, or ADHD, attention deficit hyperactivity disorder. Those would fall into that line. Then you have what more times than not, it used to be where we say these are the disorders for the elderly, but we are finding today that even younger people are getting some of the being diagnosed with some of these disorders, and that's under delirium, dementia, amnestic, as well as cognitive disorders. Here is where we're looking at damage that's occurred to the brain, particularly like Alzheimer's or Huntington's disease, where there's an actual physical trauma to the brain. And then we also have an area in which we really can't classify it. So we'll say other conditions that might be of physical, sexual, or abuse issues. They might be that's having problems with interacting with people, so we call that relational problems, as well as if you're having trouble at work, sometimes you just don't get along with anybody. We might say that there's occupational problems, and the list can go on. But these are those type of disorders that when we're looking in a DSM, there's certain classifications that's got to be met, criteria that has to be met for each disorder for us to say it's actually that disorder. If a person is not presenting with all of those and they're not falling in line with any of the other categories, then we tend to use other conditions. Now, in terms of this slide, I'm going to discuss this slide, but to be quite honest, is out of date. In terms of the textbook is still speaking of the last diagnostic statistical manual, which was the DSM-4 TR. But now we're up to the fifth edition, and in the fifth edition, we don't work by axes anymore. But I did want to still go over this with you, as if you get a test question, I want to make sure you're still aware. But I did want to make sure I update you on the fact that some of the things that you see in this list, we don't work with anymore. So we won't list clinical disorders, personality disorders, and mental retardation. As I mentioned, we now call it intellectual challenges or intellectual disability. Uh, we'll talk about one's medical conditions, but we're not listing it in this fashion. Uh, we may make mention about psychosocial or environmental issues, but again, when we're talking about straight diagnosis, the top one, number one, is what we're looking at mainly, is that clinical disorders. We may make additional mentions throughout a report, so to speak, but we're not listing them all out the way you see it here on the slide. So global assessment of functioning no longer even exists in the DSM-5. So I'm going to skip this because actually I don't want us doing axes work, but what I might say is, if we were doing it, we would look at the diagnoses of dealing with adjustment disorder. We might want to know what other medical conditions she's dealing with, and then they would ask you about the global assessment. But we don't have to worry about that today because we don't do it in that same fashion. Now, unfortunately, the history of the DSM, it does have limitations as well as potential issues and problems. Critics have suggested that it might be casting a wide net and can be overdiagnosing individuals. And given that physicians and psychologists alike, can only be compensated for treatment by the insurance company based on the DSM, if each client would be assigned this classification, you can see how it can be encouraged to add more diagnoses if you're trying to get paid. So that's a big problem. Um, there's also cultural biases that has been attached to the DSM, but in the DSM-5, they've tried to tackle cultural biases by making it more inclusive for those of other races. So let's look a little bit at anxiety disorders. I've tapped on some of them, but I did want to go into a little more depth with them. So there's five major ones that we've looked at, okay? And that would be generalized anxiety disorder, panic disorder, phobias, the obsessive compulsive disorder, which most people is more commonly known and aware about these last two, of obsessive compulsive disorder and the post-traumatic stress disorder. As you remember, we talked about it back in chapter 3. But when we're speaking about generalized anxiety disorder, this is a disorder that's going to affect women twice as much as it would men. General anxiety disorder, or GAD, GAD, is usually seen with chronic or uncontrollable and excessive fears and worries that usually last at least 6 months. And it's not going to be focused on any particular object or a particular situation. It's an overall. That's why we use the term general. So because of this, there's going to be a person would demonstrate with persistent muscle tension. They're going to have those fear reactions, fight or flight. Autonomic nervous system is going to be kicking in gear a lot. People with this disorder, they can develop headaches, heart palpitations. They might feel dizzy. They'll have problems with sleeping, so they may have insomnia. Uh, Coping is much more difficult for an individual that presents it with generalized anxiety disorder. Getting through daily activities is hard. So that's where generalized anxiety disorder would lay. Now, in terms of panic disorder, this is when out of the blue, suddenly, and it usually doesn't last really long, you have this intense feeling that for some it feels like the walls are closing in on them. They feel apprehensive. It might cause dizziness. Some may have problems with breathing, as well as just being able to, they all of a sudden they start sweating. They feel like they're about to have a heart attack. This is what we might lay under panic disorder. Panic attacks, they're going to kind of happen usually after a frightening experience or some type of prolonged type of stressful situation. But it can happen anywhere at any time, and for some individuals it can happen even within a grocery store. My sister, we went to Walmart one day and we're walking and she's fine, and then all of a sudden she just starts breathing heavy and hyperventilating. I had to get and find a paper bag to let her hyperventilate inside of her bag because she was having a panic attack. She tends to have panic attacks a lot in cars, which always makes me worry when she drives. She gets really nervous and all of a sudden she starts to have a panic attack where she struggles with breathing. So it can be really intense for a person. Panic disorder is going to be usually diagnosed when there's several spontaneous attacks that's happening, because any of us at any time can have a panic attack, but we might not go automatically assume to give you the diagnosis of panic disorder simply because you had one attack. It would have to happen in which it's would become a consistent concern that it's going to happen regularly in the future. Okay, so one type of panic attack that can happen to a person, we call it agoraphobia. Okay, agoraphobia is when a person struggles with being able to go outside their home. They have to stay within the safety net of their home. They might even be able to, some can step actually outside on their property, but stepping off their property, it becomes extremely difficult for them. Now, let's talk about phobias. Here, this is when you're having a strong irrational fear and avoidance of different objects or situations that, for some, it won't be the bother, but for others, it can be, really intense. Um, for some, they might have fears of elevators, of claustrophobia. Uh, some might have a problem with going to the dentist. Then you may have people who will recognize they'll recognize that this is rational thinking, but doesn't make it any easier for them. That experience is still it's an overwhelming type of anxiety that hits them, and with that, a person might have a full-blown panic attack to follow on top of it. Okay. So agoraphobia you may have is one. You have specific phobias. Some people have social phobias. Okay. So one moment. I mentioned already what agoraphobia is. With specific phobia, this is going to be specific to a situation. Have you heard of arachnophobia? Some people have that problem with those spiders. Uh, some people will have problems with needles, with rats, with heights. Like I mentioned, claustrophobia, that's when people are struggling with uh, dealing with close spaces. Acrophobia, that's going to be one for the heights. You see, nope, can't do it. So there are specific phobias that most often is going to be treated through therapy. And usually people with specific phobias, they know that they have these fears and that they can be excessive and unreasonable. But again, it's hard for them to control that anxiety. Excuse me. Whew, sorry. Okay. So now, where was I? Oh, I was talking about those specific phobias. it's hard for a person who have it, even though they know that they're thinking irrationally, that anxiety will still be extremely high for them, and they'll go through great lengths to try to avoid that particular stimulus altogether. Now, another thing that you need to understand, people with social phobias, they're going to be rationally fearful and embarrassed themselves within social situations. Take, for example, public speaking. Now, once upon a time, if I didn't tell you, I hated public speaking. I mean, I dreaded it. And I still do to this day. I've just learned to work through it, and I've learned to cope through some exposure therapy, by the way. But when I was in grad school and I used to have to do presentations, I would hate it, and they would hand you the mic, and you can literally see the level of anxiety physically in me because I would be sweating, I would be shaking, I would be trembling, I would start to stutter. There was all type of symptomology for me. When I went into my residency and my supervisors at Mississippi State Hospital saw that I had this phobia for public speaking, they gave me exposure therapy by having me present every week for the entire year. Um, and they're actually the ones who got me to come to Jackson State to start teaching. So, long story short, when the question was asked, can people be cured of their particular disorders? Yes, they can. There are some disorders that they're not going to be able to be cured from, but they learn to cope with it. Okay. All right. So now, okay. So when we're talking about how do we come about discussing anxiety disorders, we look at several things: psychological, biological, as well as sociocultural. Psychological is those contributions that's going to be the anxiety disorders. They're primarily going to be in the form of those faulty and irrational cognitions, as well as maladaptive learning, things that we kind of learned that really just perpetuated the problem. In terms of those faulty cognitions, people usually with anxiety disorders, they're going to have these habits of thinking, or these cognitive habits, so to speak, that makes them more prone to being afraid. They'll tend to be hypervigilant and constantly scanning the environment for signs of danger. They'll be catastrophic. They'll ignore the signs of safety sometimes altogether. So they tend to magnify ordinary type of threats and failures, and they become really hypersensitive to the opinions of them from others. In terms of talking about what is maladaptive learning, according to learning theorists, anxiety disorders generally will result from the conditioning in social learning. Uh, so you could take a look back at chapter 6 of learning to see exactly what we're speaking about in terms of classical and operant conditioning. So, like operant conditioning, remember now, this is a stimulus that's usually going to be neutral. Let's talk about a spider, for example, that becomes paired with a scary or frightening event. And it might get paired with you having a panic attack at that moment. So now it's become a conditioned stimulus that's going to automatically elicit that anxiety. A person will begin to avoid spiders in order to kind of reduce that anxiety. Now, in terms of that, now we're looking at operant conditioning, and this is what we call negative reinforcement. Now, in terms of biological factors, research has been able to demonstrate and it suggests that phobias reflect an evolutionary or predisposition to fear, which this kind of been diagnosed to our ancestors. There's been people with panic disorder, for example, that seem to be genetically predisposed toward this overreaction that's triggering off the autonomic nervous system. And you need to remember which one. Is it the parasympathetic or the sympathetic nervous system that's being activated? I'm going to leave that for you to answer. However, it kind of helps to support that argument about our biological component and how it plays a role with anxiety. Additionally, stress and arousal, they kind of play a role with panic attacks. And drugs like caffeine or nicotine, they can even trigger an attack as well. So this all allows us to realize that there is a biochemical disturbance going on, which is attributed to anxiety. In terms of social cultural factors, now we're looking at how psychological and biological components combine with social cultural factors that helps to contribute to anxiety. There's been a sharp rise within anxiety disorders within the last half century or 50 years, particularly here in the United States, where we've seen an increase of fast-paced lives. It's like I used to live in New York, and you couldn't get me to go back to live in New York because it's a jungle, literally. We call it the concrete jungle for a reason. There's over 9 million people living in New York, and the streets are packed daily. If I'm talking about New York City specifically. But along with that, there's an increased mobility. You have a decreased job security because there's so many people. Um, Sometimes it's where family support is like contribution. This all contributes to anxiety. And unlike those dangers that we face as humans in our evolutionary history, today more than ever, threats are less identifiable as well as immediate. So it leads some people to become hypervigilant, and those individuals would be predisposed to anxiety disorders altogether. So now I want you to check your knowledge. Check your knowledge about anxiety disorders. Okay? Take a look at these and go ahead and match them up. It's going to give you good practice for the examination that you'll be taking. So pause, read, and try to answer for yourself. And maybe I'll give you the answer. All right. So the next video, when we start up for part 2, we'll be going over mood disorders. Have a great one.